So good afternoon everyone. So this is a short presentation as asked by Dr. Pachori on management of chronic rhinosinusitis. We all know this scenario of sinusitis came into picture when the Messer-Klinger and Stamberger did some research work in 70s, and it was very well accepted by the world. The theory was to just open up the ethmoidal pre-chambers wherein the sinuses drain and establish the ventilation and drainage, that's dependent sinuses revert back their pathology and come back to normal. And this was so well accepted worldwide and people started doing, and so now, by now, millions of sinus surgeries have been done. After a period of time, people realized who operated the disease coming back, the polyps coming back, in spite of having opened the sinuses wide, in spite of having established the ventilation and drainage. So the researchers went into this field, why this disease is coming back, what exactly is this disease. As the name implies, that sinusitis, everybody assumes that this is infection. This is not at all an infection, this is inflammatory disease. It's a pure medical disease and the core treatment is a medical treatment. So a lot of research work done in this field in last 3 decades. Most of the work in this field was done on understanding this disease, and now we have understood this disease very well. We have reviewed around 3,000 publications in last many years. What the work going on this, how can we prevent this disease, what is the cause behind this disease, what actually we are treating. So once it comes to the treatment of chronic sinusitis, we need to treat the CRS only. We need to understand what exactly this disease is. It's not that every pathology, any pathology can give the similar symptoms. The symptoms are overlapping and we can start treating on the line of sinusitis. Getting a CT scan done where you see the inflammation in the sinuses, assuming sinusitis is operate, we can't expect a good result in those situations. So sinusitis is, this is the definition proposed by the American and the European Rhinology Society, wherein these 4 symptoms should be there for at least 12 weeks with confirmation on endoscopy and CT scan, then only it should be established as chronic rhinosinusitis. Another thing is, the diagnosis is based on the symptom, not the CT scan. CT scan is for confirmation when this symptomatology stands for more than 12 weeks. That is the indication of CT scan. It's not that the patient coming to you with the symptoms of pertaining to chronic rhinosinusitis, you get the scan done and operate tomorrow. This is not, you cannot get good results. So we need to score the symptoms, and this is the proposition SNOT 22 scoring, and this gives you amazing way of ascertaining the outcome of a patient, that what kind of symptomatology that patient is having, and after the treatment how is he improving. See, on this scoring the 5 points are given at every score. Like patient, if you get the scoring done, whomever you are labeling as chronic rhinosinusitis, you will find the patient symptom sometimes he has a non-specific symptom of sleep problem, fatigue problem, headache problem, and you ultimately will realize he is not a sinusitis, he is a psycho patient. So the scoring is very important. Even if he is a sinusitis patient, how can you evaluate the outcome? Then comes the role of scoring, and SNOT 22 is very important, and what the new evidence-based medicine says is to go by SNOT 22. Now this sinusitis has variety of situation we face. It's not all cases are same, but by and large they are divided in 2 categories on the basis of their etiology, their pathogenesis, their treatment, outcome, prognosis, altogether different, with or without polyposis. One is the purely eosinophilic driven disease, this polyposis, and one is a pure, not purely, but more often a neutrophilic driven disease, and the treatment are different, which I am going to propose. So now, what kind of work done in last 3 decades, we need to understand it at a molecular level. We went through this, and now our protocols have totally changed. So it is a pure immune complex disease. It's not infective disease at all. Infection can be just a disease modifier. No role of antibiotics as far as the core management of this disease is concerned, not at all. It is a pure immune complex disease, and like any other immune complex disease, the treatment of choice is steroids. For example, any patient with sinusitis, polyposis coming to you in your clinic, give a oral course of steroids for 15 days. He'll come back to you being so grateful, doctor, So many surgeons advised me surgery. You are the one who have treated me medically. Please continue me on the same line. You know in your hearts and hearts you can't continue the steroid for long because of their own adverse effects. So the steroid works very well. What does it mean? Steroid works for many immune complex diseases, and this is the treatment of choice. So what is understood? We need to understand our sinonasal immunity, and that is innate immunity, and then that is followed by adaptive immunity. So we just in couple of slides I'll take you to the molecular level what exactly we are treating. Can we have a pointer, sir? Yeah. So our sinonasal immunity, the innate immunity, is driven by our natural epithelium, lining epithelium with the interepithelial junctions. So intact epithelium with the tight junction prevents any noxious stimuli, maybe environmental toxin, allergen, microorganism, to invade them and give rise to the adaptive immunity. So the first barrier is epithelium, second is the mucociliary system flowing over the epithelium. So whatever these agents come in contact, our mucosa is exposed to all these all the time. So whenever they come into contact, the mucociliary system trap these and forward to the nasopharynx and then to the gut. And third is this epithelium secrete almost 1,000 variety of protein. Each and every one has been identified and described. Those variety of antimicrobial protein, enzymes, opsonin, and so many things act on those specific allergens, whatever may be the bacteria or allergen, toxin, whatever, and then ultimately degrade that. So this innate immunity is the core system which prevents us from diseases, particularly this sinusitis. And anything invades the epithelium that give rise to the origin of adaptive immunity. So what is adaptive immunity? If you see, this is the normal, these are the proteins. So what is adaptive immunity we need to understand so that we can target them. Nowadays, the future of the sinusitis treatment, as I said, the treatment is medical, co-treatment is medical. What we are treating surgically is the tissue manifestations, not the actual disease. So the actual treatment in the future is going to be the targeted therapy. So how to understand those targets? We need to understand this cascade. What happens when the epithelium is invaded by all these? The pattern recognition receptors are activated and they signal to the epithelium, and the epithelium secretes variety of cytokines, the most important being the TSLP, interleukin 25 and 23, and that activates the innate lymphoid cell 2, and which is the final destination where the T lymphocytes are activated and a TS2 or TH1 responder, T helper cell 1 or T helper cell 2 system is activated depending upon the invasion, depending upon the etiology. And once the T helper 2 system is activated, this is the hallmark of this eosinophilic disease, and this is a natural protective mechanism in response to the allergen. So once the T helper 2 system is activated, this is activated by interleukin 4, and this leads to activation of interleukin 5, which acts on the eosinophil. Eosinophils multiply and they act on the adhesion molecules on the basement membrane, and they ultimately do the final damage. The eosinophil secretes major basic protein, cationic protein, and ultimately damage the epithelium where the stimuli started. So that's how the damage starts, and then these Th2 cells stimulated by interleukin 4 and 13 activates the B cell, which secretes the immunoglobulin E, and that activates the mast cell and eosinophils, mast cells and basophils, and this immunoglobulin E is the final destination of the rest of the damage created to the epithelium. So when the sinusitis happen to take place, this is all protective in response to the stimuli. This inappropriate adaptive immunity in response to the stimuli is the hallmark of chronic rhinosinusitis. When the eosinophils are inappropriately activated and they create the tissue damage by means of major basic protein and eosinophilic cationic protein. So this is the cascade. What do we understand from this? The researchers went on this and started working on these stimulus which are working at the various level of the cascades. For example, If the TSLP is blocked, the entire cascade can be blocked if it is blocked proximally here, and the eosinophils will not be stimulated. If the interleukin 5 is blocked by the monoclonal antibodies, the eosinophils will not get activated, and you can prevent the final damage. And this is the future of the sinusitis treatment. I will escape all these because of the time. So what is the targets that we have achieved now? The monoclonal antibodies have been approved by the FDA, and the top 4 companies like GSK and all these are marketing. They have started marketing on this. So what are the antibodies, monoclonal antibodies we have got in the market now? I'll tell you. See, the first one is to block the production of interleukin 25 and 23, and here the monoclonal antibodies have come in the market. I will tell in the next slide. Anti-interleukin 4 antibodies, anti-interleukin 13 antibodies, anti-interleukin 5 interleukin 5 is the hallmark of eosinophil damage. Why it is coming back? And anti-IgE antibodies. If we target these 5 targets, which are the activators of this entire cascade, we can stop happening this eosinophilic sinusitis. So what are the antibodies? The anti-IgE, which is very common in the market, the physicians are using to treat the very, very resistant asthma, that is omalizumab. This is marketed by the GSK. Anti-IL-5 antibody, which is mepolizumab, it is marketed by Sanofi Aventis. Anti-IL-5 dupilumab, benralizumab, all these antibodies are now in the market. FDA is approved, and if we use, this is a medical disease, if we block the sinusitis cascade by using these antibodies, the further treatment is not required. But this will take a lot of time to come in the clinical practice and to establish their role as a therapy for the long-term treatment. But this is going to be the future. Until now, we don't have any option but to use steroids, and if you can't use steroid to treat the tissue manifestation via the sinuses, we treat by means of surgery. So once it comes to diagnosis, what can we do? Commonly we do the nasal endoscopy and CT scan. And what you do in CT scan, we have already discussed what kind of a CT scan we need. I will just skip it. So what other things you need for the diagnosis? You need certain investigations done, not only for the diagnosis but to prognosticate the patient, to know the actual status of the patient, what kind of disease he is having. You can tell your patient beforehand that this is your disease load and you need this kind of a treatment post-operatively. You have to tell them what kind of a treatment you need post-operatively. Patient may ask you, I am getting surgery done, will I be cured after that? Will I need any medical treatment after that? You have to tell them. If it is a eosinophilic disease, the patient will need long-term topical steroid post-operatively. So we have to get these investigations done. For example, IgE is a very, very important tool. If the patient's IgE is low or normal, 80% of the patients do not need surgery. Surgery is used to treat the disease load, eosinophilic load. If the load is not that much, the surgery is not indicated. See, the simple funda, if you give steroid, disease, the manifestations are taken care of. We can't use oral steroid, so we resort to topical spray. If the disease load is too much, that cannot be taken care of by topical spray, then obviously you have to treat by surgery. So you get to know if the Ig is low or normal, you can keep all those patients on macrolides, and 80% of the patients do not need surgery. Similarly, antibiotics, 99% of the time sinusitis should not be treated by antibiotics. The reason being, in case required, because of the secondary infection, you can get a culture sensitivity done, and accordingly you can give antibiotic. And a simple test is 10 rupee test. You get a procalcitonin or CRP done. If the CRP is normal, that rules out bacterial infection. No point in giving antibiotics and giving further damaging the resident microflora. The important thing, these are all important things, aspirin, sensi, I will tackle them later on. But the most important being the vitamin D. Vitamin D is the main immunoregulatory hormone for the respiratory epithelium, maybe the upper airway or lower airway, and most of the people develop complications or the extensive disease in sinusitis is because of vitamin D deficiency. This is how vitamin D works at various level in the inflammatory disease, particularly in this CRS. And if you start getting vitamin D, those who are deficient, if you fulfill the vitamin D level, if you give the supplements, they do very well. And most extensive patients like allergic fungal sinusitis and patient presenting with a lot of headache and pain are mostly vitamin D deficient, and this is prerequisite to restore the vitamin D deficiency. Second is, get the histopathology of the specimen you remove. It gives you a lot of prognostic information. Like, the most important thing is the tissue eosinophilia and the basement membrane thickness. If the basement membrane is too thick, that means the remodeling is going on and patient will require lifetime treatment. He has already developed the irreversible phenomena in the mucosa, and you have to treat it topically with the steroid long term, and that topical treatment will be possible only when you open up the sinuses. In the closed sinuses, you can't deliver the topical steroid. There comes the role of sinus surgery and the eosinophil count. Any patient more than 10 eosinophils per high power field, you have to tell him, boss, you have to take long-term the topical steroid irrigation, otherwise your disease is bound to come back. So you have to tell, otherwise patient will hit your head and you will be in trouble. We need to know what the patient kind of disease is having and what you are exactly giving to the patient. He should know what kind of disease he is having. So what are the management options by and large to us now? Number one, obviously, as I said, corticosteroids, and the most effective is oral, but we can't give oral, so the only option left to us is topical nasal sprays. Now the problem is, in the untreated sinuses, nasal sprays do not penetrate. Even in the treated sinuses, nasal sprays do not penetrate beyond more than 1/3 of the anterior part of the nasal cavity. And in the closed sinuses, you can't deliver the topical steroids by means of any irrigation solution because the irrigation doesn't penetrate. So only option is topical steroid you have, and if the patient's disease load is too much, that cannot be taken care of by the topical steroid alone, then comes the role of FAS. So there are only two situations where the FAS is indicated: when the disease load is too much, that cannot be taken care of solely by the topical steroid. So then you reduce the inflammatory load. And the second thing, establish the ventilation and drainage and access to the topical steroid. Pre-operatively, the topical sprays do not penetrate. Post-operatively, now you can give the long-term topical steroid irrigation right at the destination to the sinus mucosa. This is the disease of the mucosa lining the paranasal sinuses, and we have to deliver steroid right over there so that we can avoid the use of oral steroids. Post-operatively, you never have to give oral steroid. The reason being, you have the access now for the topical steroid to reach everywhere in the sinuses. So there comes the role of FAS. Every patient doesn't need FAS. The role comes when the topicals do not work, and the disease load is too much, then the option is FAS. But the future is, which is not practical now, which is not popular now, which is not feasible now, is the targeted therapy. If you target the activators of this disease, which are involved in the cascade of this disease phenomena, you can prevent the tissue manifestation. So you have to target the disease proximally to prevent these tissue manifestation, which led to the need of the sinus surgery. So we need to understand what we are treating. Sinus surgery is not the primary answer to this disease. Primary answer is medical. Primary or future, the treatment is medical. The surgery has some indication in situation when the disease load is too much. So now, it has been a standard practice that patients should be given a full medical treatment, appropriate medical treatment, whatever you call it, before you take up for surgery, and if patient doesn't respond to it, then only the surgery is indicated. So as I mentioned, what all you can give? Topical steroid, maybe with or without polyposis. Adjuvant to this, what else can work is the saline irrigation to wash out the mucus, infiltrates and allergens, everything. So saline irrigation and topical steroid is the only medical management by and large. Other things which can work to some extent, add on to this therapy to reduce the disease load so that you can avoid surgery. In some patients it can work like montelukast in polyposis and the oral corticosteroid burst for some time. Like the patient has a burst of symptoms, you can give a 5-7 days course of oral steroid. That's not the final answer. So the two things which can be added to reduce the disease load to at the most, which can be done, is montelukast and oral antibiotics. Not as antibiotics, as immunomodulators. For the non-polyposis disease, the macrolides are the immunomodulators, and for the polypotic disease, doxycycline is the immunomodulator. So that can be added as an adjuvant not as an antibiotic, as an immunomodulator. And antifungals have absolutely no role in the management of chronic rhinosinusitis. Even if it is fungal, antifungals are indicated only in invasive fungal disease. That's it. Even in the allergic fungal polyposis, that's an immune complex disease. I'll come to that. There is no need of antifungal agents. So topical steroid is the final answer. The option is the mometasone and the fluticasone. I'll skip. So doxycycline, as I mentioned, can be used as an immunomodulator for the polypoidal disease, and it acts at various levels. It has been proven in a lot of studies. You can give a course of 100 milligram a day for 20 days maximum, and it helps to reduce the disease load in the polypoidal disease. That is an adjuvant therapy. It may work. It may not work always. And same, the macrolides for the non-polypoidal disease, and it works at various levels and inhibits the neutrophilic action by various ways. So doxycycline works at the eosinophilic level and the macrolides at the neutrophilic level. And so when can be given macrolide? As I said, when the serum Ig is low or normal, you can use macrolide, and they work. And 80% of the time, this non-polypoidal sinusitis can be treated medically without any need of surgery. And the other indications of macrolides in cases of biofilms, in cases of resistant disease, in cases of the other situations we'll take later on. So the other things, I'll like to enumerate certain situations. See, sinusitis is not a solitary disease, it's a sort of syndrome. We need to take up it as a syndrome, and we need to treat the adjuvant situations also. If you don't focus on this, the ultimate outcomes are never good. So these are the things which can further complicate this course of sinusitis. The allergy, asthma, smoking, I'm not going in detail, but this has been studied both so extensively. Immunocompromised patients, I'll mention here, this immune complex disease, 10% or up to 10% of the patients of sinusitis have some sort of immunodeficiency, and you can pick up those patients requiring a recurrent purulent discharge, needing again and again antibiotics, needing again and again oral steroid. Are those patients who are immunodeficient, and we should get the immunoglobulin levels and treat them. Otherwise, if you operate on them, never expect a good outcome. Biofilms, I'll take them separately. I'll skip all these. This is one thing I'll specifically mention, the aspirin exacerbated respiratory disease. We have now more than 300 cases. This is one endotype of sinusitis which is the highest level of inflammatory spectrum in this disease. If you don't understand and don't treat on that particular line, it is bound to come back. 100% it is going to come back. This has the highest level of inflammatory spectrum in this disease. So what happens in aspirin? People who are sensitive to aspirin. Aspirin is what? It's a COX-2 inhibitor. It inhibits the cyclooxygenase enzyme. So patients, what happens in the body when the arachidonic acid is metabolized? The cyclooxygenase work and produce the prostaglandins, which are anti-inflammatory agents. Similarly, arachidonic acid can be metabolized by the lipoxygenase into the leukotrienes, which are highly pro-inflammatory agents. So COX-2 inhibitor sensitive people, the aspirin sensitive people, their cyclooxygenase doesn't work, and most of the arachidonic acid is metabolized into leukotrienes, which are highly inflammatory at the upper and lower airway and produce symptom like anything. And if these leukotrienes are not taken care of, this aspirin sensitivity is not taken care of, you may operate 100 times, patient is going to come back again and again. So we need to understand in people, up to 20% of the patients with polypoidal disease have hypersensitivity to aspirin and other NSAIDs. If you take the history from those patients, if they are sensitive to painkiller, it will immediately be evident to you that this is that group of a patient. We need to treat them with a desensitization afterwards, otherwise it's going to come back. In polypoidal sinusitis, the recent recommendations from the American Rhinology Society to get aspirin sensitivity testing done in every patient, like you get a drug sensitivity by the subcutaneous method. Some people do by the inhalational method, by the lyophilized aspirin and all. So management is, for aspirin sensitivity, these have the highest level of inflammatory load. So to reduce the inflammatory load, because it cannot be taken by the oral steroid, topical steroid alone, you have to do a full house fast, open up widely so you can deliver high dose of topical steroid without any side effect. And the xylitol and montelukast work well because montelukast is anti-leukotriene. And the main treatment is aspirin desensitization. These patients should be offered aspirin desensitization, otherwise they are going to come back. And simply you can do, but you have to do in the ICU setting, because you have to start with a low dose aspirin and patient can develop severe asthma and severe symptomatology. The methodology is you have to admit patient in ICU for 3 days. It has to be done post-operatively, because once you start aspirin, otherwise you cannot operate then. So after the surgery, topical irrigation, after a month or so, you have to tell them, get admitted in ICU. Start with a low dose, 30 milligram, after 3 hours increase to 60. When symptoms develop, you have to treat them symptomatically by the vasodilators or bronchodilators and all, steroids and all. And you have to sensitize the patient. In 3 days, you have to take the dose even up to 600 milligram. Once it starts digesting, the patient can take even the higher dose without sensitivity. When the patient starts sensitizing, the aspirin, the leukotrienes stop forming, and the patient relieves from this massive problem like anything. So desensitization is very, very important. Biofilms are common causes. I'm not going in detail, but here is one situation where the macrolides. Biofilms are what? This aggregates of bacteria on the sinus mucosa, where they shed for themselves as a protective proteoglycan shell. So that protects the bacteria from the patient's immune response, the human immune response, as well as from bacteria. Even the 1,000-time concentration of the bacteria, antibiotics do not work when the bacteria are protected by the biofilms, and you need to treat those patients differently. Otherwise, these biofilms keep on releasing the virulent bacteria from time to time and aggravate the situation. So there are various ways to treat. The 3 situations, we have tried everything mentioned in the literature in our practice, but now presently what we have been doing is the biofilms are most difficult thing to treat, and the 2 bacteria which form biofilms which are difficult to treat are the Pseudomonas or Staph aureus. Staph is more prevalent in the sinus diseases. So what we have been doing is a tobramycin saline irrigation. 5 ampoules of tobramycin and 1 liter of saline, ask the patient to irrigate, and it works well in the Pseudomonas infection. For the Staph, mupirocin irrigation. In India, mupirocin is not available in the powder form, but we acquire from the manufacturer. But this is a very, very costly molecule. We acquire, the cost of 1 kg of mupirocin is now over 2 lakhs. So we have to tell patient this is very expensive, and this is something which works very well topically onto the Staph aureus infection. You don't need any systemic antibiotic. And this one is very, very important, colloidal silver. You can acquire from the managemnt.com. And this silver is the strongest antibiotic on the planet. Silver is used for very, very serious infections, and this colloidal silver is now available in the medicated nasal spray form, and it works very, very well. And the last is the Manuka honey, which we acquire from New Zealand. The only company which makes this is the Watson and Sons from New Zealand. There's a special medicated honey containing methyl glycol. Is a very, very strong antibiotic for any bacteria on the planet, and this has to be applied topically in the resistant infection. So biofilms need this kind of solid treatment. Otherwise, the normal antibiotics, even at the 1,000-time concentration, do not work. So for biofilms, you have to have some specific treatment. This is the Manuka honey that you can acquire from the New Zealand, and this is silver spray available. You can buy from the Amazon. Osteitis is another problem when the disease is so extensive and the underlying bone gets inflamed, and that becomes the source of inflammation. For the persistent inflammation, acts as a depot of inflammation that we need to know. Regarding the adjuvant treatments, there are n number of drugs you may see on the prescriptions from the doctors prescribed for the sinusitis, but very few work. Antifungal, no role, 0 in any given situation except invasive fungus. Mucolytics, by and large no role, but N-acetylcysteine, iodostine having anti-inflammatory activities in the literature, and a lot of people propose them in the sinusitis as well. Decongestant, antihistamine, no role. Antihistamine has only role to control the symptom of allergic rhinitis. That's not the treatment of allergic rhinitis. The only treatment of allergic rhinitis which can complicate to the sinusitis is immunotherapy. That's the only thing which can change the natural course of allergy. Antihistamine just symptomatic. Bacterial lysates coming up as a number 1 role in the treatment. They are basically to improve the nasal microbioflora. It has been studied now in literature very extensively. To improve the host immunity, you need to improve the nasal microbioflora so that the patient innate immunity is improved. So we saw from the beginning, it is the fault in the innate immunity or the adaptive immunity. Anything which improves the immunity is going to work against this disease. Anything which reduces is going to worsen the problem. anti-leukotriene therapy in some cases of polypoidal disease and immunotherapy, yes, for the allergic rhinitis. So antifungal, no role. Allergic fungal sinusitis is a different disease. It's a medical disease, and Bent and Kuhn criteria, these are the 5 criteria by means of which you can diagnose. It is allergic type 1 hypersensitivity of the patient. We are all exposed to fungus every time in the environment. If I am allergic to certain fungus, my body will start reacting if it is deposited somewhere in the sinus after the inhalation. And that leads to that eosinophilic reaction of the person, leads to this kind of formation, this kind of hypersensitivities, and then you have to treat, remove this inflammatory load, do a wide full house endoscopic sinus surgery. And type 1 hypersensitivity means steroids, so you have to give post-op topical steroid. No role of antifungal at all. So now the question is, when to stop medical treatment? You started the patient on the medical treatment, appropriate maximum medical therapy. When to stop, when to take up for surgery? This is a very, very important question, and there is always a trade-off between the surgery and the medical treatment. So these are the proposed guidelines and published in 2016 in the International Rhinology Journal, that what you can do for polypoidal, non-polypoidal disease. The maximum treatment is start with a nasal saline irrigation for more than 8 weeks. You can give topical intranasal corticosteroids for more than 8 weeks, short course of oral steroids. If even after the completion of 8 weeks, his SNOT 22 score is more than 20, I mentioned in the beginning, you have to score the patient for the evaluation of the response. If the SNOT 20 is more than 20 and Lund-Mackay score is more than 1 on PNS, that is scoring system of sinusitis on the radiology. If it is more than 1 after the maximal medical treatment, that means that patient's inflammatory load is not being tackled by the medical treatment. You have tried maximum and he is the candidate for surgery. There is a clear-cut guidelines now. Same is for the non-eosinophilic or the non-polypoidal sinusitis. So we need to have a clear thing in mind when to operate, when to give medical treatment, so that we can appropriately treat those patients. So now there are certain situations where you don't need a medical treatment. There are certain situations when the patient needs a direct sinus surgery without wasting time in medical treatment, and these are the patients when the patient comes with a complication or have impending intraorbital or intracranial complication, and these are mostly children who come with orbital complication. Adults come with an intracranial, and then you obviously have to treat. Fungus, like we discussed, is an antigen, and once patient has a fungal disease, you have to remove it and then follow with the irrigations. So fungus means no wastage of time in medical treatment. No allergic fungal or any fungal will be cured by the antifungals. You have to remove it. Dental cause of sinusitis, you have to treat the sinus and treat the dental cause. No need of medical treatment. And similarly, the mucoceles are clear surgical entities. One situation, anatomical variance. This is a gray zone now. Lastly, I am coming up. This anatomical variance. Now you have to use your conscious and take decision appropriately. The patient has a paradoxical turbinate, has a concha bullosa, predisposing maxillary sinusitis again and again. You give a course of oral steroid and antibiotics, works very well. Again, patient comes after a few weeks with the same symptoms. You get the CT scan and everything cleared, but you see the concha or some paradoxical or something. So, why it is gray zone? You have to use your conscience that if the patient has some predisposing anatomical abnormality, you need to take a call. You need to tell the patient that you may be cured with a medical treatment from time to time, but ultimately you need surgery, and why not to take this call before and why to unnecessarily suffer from this problem again and again. Polyps again is a gray zone. We know polypoidal disease, you can put on nasal spray, oral steroid time to time, and patient can linger on for years together. But now again you have to take call from the day one, explaining patient, polyp is a hallmark of severe inflammatory load. You can linger on with time, for time being, for years even, but ultimately you will need surgery. So you have to tell from day one, yes, you can continue, you can buy the time with the medical treatment, ultimately you will need surgery. And the last one indication is the number one indication proposed by the American Rhinologist Society. Being the member, I am annually there in the meeting. This is the number one indication. Any patient requiring oral steroids to control his symptom more than twice in 3 months, That means that patient has a very severe inflammatory load and take a call for surgery rather than wasting time in the medical treatment. So this is a clear-cut indication. Any patient coming to you needing again and again oral steroid, better to take him for surgery irrespective of the CT or endoscopic finding. The reason being, once you operate, open up all sinuses, you make him use the topical steroids so that the oral steroids are not needed in the future. So you have to develop some strategy. The patient doesn't need oral steroids in the future. So I will skip these surgical parts. We have already discussed during surgery the some points. For surgery, the important thing is optimize the surgical. It's the bloodless field which is important. Otherwise, if you don't identify the landmark, you'll end up with complication. Mucosal preservation is ultimate goal. If you don't preserve the mucosa, you can't achieve the goal. And full house, so that you can allow the steroid to reach everywhere. So now you need to tell the patient that how to irrigate in which position so the steroid can be reached everywhere. This mucosa needs steroid, this is immune complex disease, that's it, we have to keep in this thing in mind. Secondly, the management of the septum, middle and inferior turbinate. This is required in almost all patients to optimize the result, to allow the steroid to reach everywhere. And sometimes the extended procedures are required according to the disease, like Lothrops and all. Lothrops is required mostly in a primary situation. The primary is generally not indicated, but when we know the disease load is so much, take a call at the beginning, like if patient has a AERD, aspirin exacerbated disease, take a call of Lothrops is a bilateral frontal disease, so you can deliver a steroid in a high dose in that particular patient. So irrigation is must, and you need to take call. Pediatric, I'll skip just one thing. Most of the pediatric sinusitis patients are related to the, besides many causes, the adenoid is another one of the cause which harbors biofilms and keep on secreting those virulent bacteria and modify the disease and lead to sinusitis. So in patients who are not responding to the topical treatment, before contemplating or thinking of sinus surgery, the first treatment is the adenoidectomy. This is one of the indications for adenoidectomy in children. I'll escape this cystic fibrosis. Now lastly, the post-op care. This is important. Somebody asked me during the lunch to speak a word about the post-op. This is very equally important. You have selected a good patient, done a good surgery. If the post-op is not taken care of, everything can go waste. So in the post-op, these are the things which are to be done. And the number one thing is the saline irrigation. That will wash away all the inflammatory mediators, all those blood clots, any remnant packing, anything. And that should be washed off from time to time to prevent crusting. Because if the crust form on the mucosa, it won't allow the steroid to act on the mucosa. It won't allow the healing to take place and the mucociliary system. So time to time, debridement of the crust from after a week or so, saline irrigation, initially some systemic steroid for good healing and systemic antibiotics also. But ultimately in the long run, it is the irrigation which is going to work. I'll just cut short it. Hyaluronic acid gel has been proposed nowadays to improve the improve the course of healing in the post-op period. Now this is one thing which is very popular in the US, not in our country, and the cost is a big factor, is the use of Propel. Propel is the only FDA approved drug-eluting stent. See this, what kind of a stent is this? It's like a spring mechanism. It keeps the ethmoid cavity open, and it contains mometazone and keeps on eluting mometazone from time to time for 3 months. And a very calculated dose, and so the steroid is eluted in the cavity on a regular basis. You don't have to do irrigation, you don't have to do anything, just put a stent and after 3 months again put a stent. But this costs $750, so it's not feasible in the country on a regular basis of the common use. So finally, the role of sinus surgery is, besides taking care of the disease load, is to give access to the topical steroid. That's the main hallmark or the gain what we get from the sinus surgery, and it depends on so many things. What kind of delivery you are giving, what is the delivery technique, what is the delivery device, the dynamics of the fluid, what is the volume, pressure, position of the patient, what kind of a cavity you have given. If you have done a mini face, how can you expect the solution to reach everywhere? So you need to give a thorough, straightforward cavity where the steroids can reach. That's why you need to treat the turbinate, septum, all these things to allow the steroid to reach everywhere. So nasal anatomy is very important. So 2 positions we propose. This is the one. head down forward position. After doing a sinus surgery, we keep a patient in a hospital for another day to train him for this and to make him do in front of us several times so he can go back and doesn't spoil our results. This is important for us. If the patient doesn't irrigate, that he'll come and fall upon you that I'm not getting good response. So this is one position, we call it as a namaz position, head down forward position. This allows the solution to reach everywhere in the frontal sinus, sphenoid sinus, and even in the olfactory region. What? No, this is the picture. We use a rubber bulb, simple 10 rupee rubber bulb, and the solution I am coming to, fill the solution and ask the patient to squeeze. So that's a high volume, high pressure irrigation of the topical steroid. You can give high dose topical steroid without systemic side effect. Studies have been done on the budanous side, used for 2 years, yet no effect on the hypothalamic pituitary axis. So that's a very, very safe thing rather than giving oral steroid. Some patient cannot do this namaz position and then can be advised this lying head back position. This is very, very important. Sometimes the elderly patient cannot do, and this again allows the solution to reach everywhere. It's not that irrigation, so many things are important for the irrigation to reach everywhere. If you are irrigating, if you're not reaching at the sinus mucosa level, it's going to go waste. So this is very, very important. And lots of delivery devices are in the market, but ours is the simple, like Madam asked, that the simple 10 rupee rubber ball. Now the state of the cavity, it matters. Suppose you have done a mini fess, the solution is not going to penetrate everywhere. You have done a good fess, but the axis is not good because of the high deviation, turbinate is lateralized and it doesn't reach effectively. So you need to give this kind of a cavity. Through and through, you need to treat septum, you need to treat turbinate and give this kind of a cavity for thorough irrigation. So what kind of a solution you use? You can use many, but our solution, these are situations when you use in the severe condition, but the situation of the solution of choice we use is budanoside respules, which are usually are meant for the treatment of nebulization for asthma. So 2 respules of budanoside mixed in 1 liter of saline at approximately 0.25 milligram per 250 ml, which is used per day. So 250 ml a day means 0.25 milligram steroid, that too in the topical dose. It doesn't affect as far as the hypothalamic pituitary axis is concerned. That is the safest one. So to conclude this, CRS should not be taken as a solitary disease, a multifactorial disease. We need to understand the pathology and various endotypes, phenotype. All diseases are not same. We need to categorize the patient what kind of disease is having, and we need to understand it's a pure medical disease. Co-treatment is medical. Surgery has some role, some place when the inflammatory load is too much and to avoid the need of oral steroids, and the mainstay of treatment in the post-op is the post-op irrigation with the topical steroids, and the future is targeted therapy. That's again a medical therapy. Thank you so much for your patience. Yes, please. Yes, please. Yoga's role is everywhere. Yoga's role is everywhere. That treats at least the mental part of the patient. That is very important.
Satish, one is do you think there is any role for anti-histaminic?
What is the role of nasal douching?
This is
The nasal douching is important with the irrigation post-operatively, as I mentioned. So your question, madam, is the role of antihistamine. Role of antihistamines. See,
Pre and post, both.
what does antihistamine do? They block the H2 receptor. So if the patient has allergic rhinitis, how the cascade forms? The allergen comes in contact with the nasal mucosa, then the eosinophilic driven pathway starts and the basophil, the mast cell degranulates, the histamine generates and histamine acts on the H2 receptor to give symptoms. So what does antihistamine do? It blocks the H2 receptor to prevent the symptoms of allergic rhinitis. That's it. It has nothing to do with the entire cascade of allergic rhinitis.
So you don't use
It
it.
acts at the end spectrum at the molecular level, blocks the H2 receptor. That's it.
Okay.
So for allergy, the only treatment which changes the natural course of disease is immunization. And we have been doing, more than 5,000 patients are on sublingual immunization. amazingly
Stop
effective.
using this now.
Antihistamine for symptoms. If the patient develops symptoms, you have to give something.
Sneezing and excessive rhinorrhea.
Yeah. Any symptoms, antihistamine will work.
And second thing is, for how long, for how long you use macrolides and doxycycline?
Macrolides are to be used, as I mentioned, not as antibacterial. They are anti-inflammatory agents. And like the commonest macrolide we use is a clarithromycin in low doses, 250 milligram a day for 3 to 4 months. And we have to tell patient this is not antibiotic, we are giving it a low dose as an anti-inflammatory agent, and it works very well. It can be given as an adjuvant treatment in the post-operative period. Some patients develop because of not a proper healing, because infection and all these things, and macrolides are very, very important. This is the only drug which prevent the biofilm formation. See how this biofilm form. The bacteria have a strategy of quorum sensing. There has to be some quorum of bacteria to form the biofilms. So this macrolides inhibit the quorum sensing of the bacteria to prevent the biofilm formation.
So doxycycline also for...
Doxycycline works very well, but only in polypoidal disease.
For that long only?
Yes, for 20 days. 100 milligram a day. First day you give 200 milligram, then 100 milligram a day for 20 days.
And how you treat the biofilms?
Biofilms, I mentioned 4 things, the 4 agents we are using. Tobramycin irrigation, mupirocin irrigation, then colloidal silver and the Manuka. Manuka is very costly for the patient. Mupirocin is very costly, but in the extreme situation you have to give.
So how do you diagnose that biofilms have formed?
Yes, that's a very important thing. The ideal thing to diagnose the biofilms is the hybridization technique. Fish hybridization technique with electron microscope. That is the ideal thing. No other thing can diagnose. But there are ways. Like how do we find out? We send the mucosal sample to the pathologist and they do H&E staining. E staining to find out the bacteria on the surface.
Okay.
Number 1.
Just
They cannot discriminate which bacteria, whether it is Pseudomonas or Staph.
Okay.
Now to know what kind of bacteria it is, keep on sending the regular cultures. When the biofilm delivers, biofilm emits the virulent bacteria, they can be caught in the culture. Can be diagnosed. So you have identified on one side, on the mucosal sample, there are biofilms. Now on the cultures, repeated cultures, you get to know that this is Pseudomonas, then you target the Pseudomonas biofilm. That's how indirectly, otherwise you need electron microscopy or the fish hybridization
So
technique.
you just take it with the swab stick through from the nose, mucosal sample.
Yes, no, mucosal sample, biopsy.
Biopsy layer.
Yes, the biofilms are on the mucosal surface.
Okay.
So you need to take biopsy to diagnose them. Sir.
We have a couple of patients, both unfortunately doctors, who had MRSA sinusitis, and both turn out to be very aggressive disease. One developed meningitis.
Mupirocin, we have treated so many. I will give you the address of the company which provides mupirocin powder. 2 lakh rupees a kilo. So you have to use 5 milligram in 100 ml of saline and you irrigate. It works like magic for any MRSA infection. Otherwise you keep on giving injectable antibiotics, they do not penetrate biofilms and it doesn't work. Ringer is always better. See, it has been proven now, the recently published in laryngoscope. Ringer is more physiological. It contains besides the sodium and chloride, the calcium and lactate also. And that is a more physiological solution to the body surfaces or the mucosa or tissues.
One more.
What?
What is the incidence of NARES?
NARES is what?
What is NARES? Non-allergic
Non-allergic?
rhinitis.
Rhinitis is different thing, sir. I have got your point. Rhinitis are various types. The non-allergic, allergic, the atrophic, vasomotor, and different. That's a different topic. I can't comment on this. I have no experience of treating NARES.
One last question.
Yeah.
You talked about monoclonal antibodies. So omalizumab is available in the market.
Yes,
It's used
these
in
are
asthma.
available. Yes,
Can we
these are
start
available.
using it in sinusitis also? I mean, role in rhinosinusitis. Can we start using it without the trials
Yes,
and all?
FDA is approved.
It's expensive, but
FDA is approved. It is very expensive. That though the one dose of this omalizumab is more than 30,000.
but those who are affording
This is
should be,
a subcutaneous injection that you have to repeat after a couple of weeks again and again. And mostly the people who are using omalizumab are for the patients who have resistant asthma to every possible treatment. Patients in status asthmaticus and those, because that is the end spectrum of heavy eosinophilic disease in the lower airway. So it is being treated extensively in asthma patients.
Dr. Satish, for how long have you used montelukast?
Montelukast you can use
Do
for
you have
long, and studies have proved even for 6 months, 1 year even.
But not beyond that.
Yeah, see,
Okay.
role of montelukast is limited as an adjuvant treatment in polypoidal sinusitis. That's not a
So
definitive
we
treatment.
will prefer rather topical steroids than using montelukast.
Yes,
for
topical steroid the answer, but the limitation is
Again,
the
it
topicals do not penetrate more than 1/3 of the anterior part of the nasal cavity. These nasal spray, fluticasone, mometazone. Radionuclide stent studies have been done with a spray. They do not penetrate. You push it, lasts in the anterior 1/3 of the nasal cavity. We want that penetration in the sinus mucosa.
मजा आ गया.
So that's why irrigation is required, and to make that effective, you have to open up sinuses. The role of sinus surgery to give access to the topical steroids.
Similarly, antihistaminics maximum.
Antihistaminics are to be taken only to control symptom of allergic rhinitis, as and when required. So you have to treat with immunotherapy. That can only cure the allergic rhinitis. Rest is all symptomatic.
very, very informative lecture. Dr.
Huh?
You said about the steroid irrigation.
What's that?
Steroid is how to prepare the steroid irrigation.
Irrigation, you have to mix, depending upon the severity of the disease, by and large, 2 respiles of budesonide in 1 liter of saline. That approximates to 0.25 milligram of budesonide in 250 ml. That's the solution we advocate every day to irrigate with 250 ml, 125 both sides.
So you don't mix soda bicarb?
No, nothing. We need steroid bus. That's it. Steroid is going to work. We don't have any other weapon to deal with this disease else than steroid.
Satish, one last question. You have a solid load of sinusitis patients. With this sort of knowledge, has your incidence of operating on sinus gone down, or you are operating the same number?
Yeah, primarily gone down, but we have more than 40% lot of revision patients. The reason being, most of them, those patients were those who actually didn't need a surgery. What happens? These patients, the kind of symptomatology they have, that they remain unaware of this for years together. Once they are treated and do not get well, then they become psycho, they need treatment now. So this is something we need to think twice before advising surgery. That's why SNOT 22, you get the scoring, you will get to know his mental level on the paper, that what kind of mentality is having. On the SNOT 22 scoring, what are the symptoms? He will say, yes, I have fatigue, I have this headache, I have sleep problem, I have this. So all these are not symptoms of sinusitis.
So you use this SNOT 22 scale for each and every patient?
Yes, then only you can evaluate the response. How will you? Looking at the state of the cavity is not the only way to evaluate. It's the patient's symptomatology. The diagnosis is only based on the symptoms. Thank you, boss.
So very nice illustrative lecture.